Let me bring you into my clinic. I want to talk to you about how we assess our patients. So, how do you take these concepts of natural living and plant-based eating and all of that stuff, and how do you apply it to the patient in front of you? And that's what I want to talk about, because it's one thing to talk about the concepts, the literature, the theory, but I really want to bring this home to you. So how do we make this practice? So patients that come to our center, and we're just 4 miles south of the world's largest medical center. We have our small little medical center, it's an independent facility. Patients come and we evaluate individuals with complex illnesses. Most of our patients have cardiovascular disease. However, due to the nature of the work that we do, we see patients with many other illnesses who come with complaints of metabolic illnesses, cancer, lung disease, inflammatory conditions. So we do treat a broad scope of patients. Our first approach is to take a comprehensive history and physical exam. This is really the most important part of the assessment. This allows us to get to know the patient. This allows the patient to get to know us. It allows us to create some rapport with the patient. And that's very important in, number one, coming up with a diagnosis, and number two, getting the patient's buy-in on the treatment that we recommend. So first of all, it's a history, physical exam. I was taught in medical school, roughly 85 to 95% of your diagnosis is made based on the history and physical exam, not necessarily the blood test that you draw. Once we've taken a proper history and physical exam, which also includes an assessment of their lifestyle, which typically isn't what most history and physical exams have. So once we've gotten a comprehensive physical history and physical, we take biomarker tests, we get lots of blood tests to measure not only the typical lab tests. We get tests to look at inflammatory markers. We have an inflammatory score test that can give us an assessment as to whether the patient has unstable plaque in their coronary arteries. We have a micronutrient test that looks at intracellular and extracellular nutrients and looks at some of the biochemical pathways to give us some assessment as to whether the patient has toxin overload with lead, different things that gives us some insight as to what's going on with the patient. Because oftentimes, the abnormalities or symptoms, it's not found on or cannot be verified based on simple, CDC and chemistry blood tests, but we do much more in-depth tests. And I'll give some examples of some of that in some of the patient examples. We do non-invasive testing in our facility. And of course, we're just 4 miles south of the medical center, and we do manage our own patients in the hospital. And we go through that. And I'll go through some of that in some of the upcoming slides. So a little closer look at the integrative intervention. We start off with the medical assessment, as I said, and we look at the medications our patients are taking, and we try to remove all unnecessary medications. Sometimes that's the simplest thing up front. A patient may come with swelling or some other symptom, and many times we can make an assessment as to whether those symptoms are due to a medication side effect. And so sometimes it's a simple matter of reducing a medication. Some patients are taking lots of over-the-counter supplements that we can simply reduce. These things may be causing symptoms, maybe causing their blood pressure to be elevated. So sometimes by just removing certain things, we can have a major impact in a relatively short order in managing our patients. And of course, our facility has capabilities of giving intravenous fluids, some intravenous medications. And so we can do some things in our office that may prevent the patient from having to go to the emergency room. And I'll share some information on that in some of our case examples. And of course, we go with a nutritional, or I should say that part of the integrative intervention is a nutritional prescription. So it's a food diary we take from the patient. And sometimes this is based on a 24, 36-hour recall. We will also review their health goals, whether they're trying to achieve. Some people come in and say, well, ask what brings you here today. They may say, well, I just want to lose weight, or I want to get off my medications. And, these statements are really important because that helps us zone in on where the patient's mind is in terms of what they want to achieve. We may have a broader recommendation or broader scope, but it helps us understand where the patient is in their immediate desires. We consider detox plan, medication weaning, and we look at other approaches, and we'll discuss some of those other approaches that we have in addition to the nutritional approach. So We also have the capability of doing minimally and non-invasive medical treatments. As I said before, we can give intravenous therapies. I've had patients coming in with decompensated heart failure. They're very short of breath. And there have been occasions where we give them intravenous furosemide. We'll observe them in the office, monitor oxygen saturation, and we've seen patients improve acutely. And so we can avoid an emergency room visit. We're able to get blood tests on site and have them come back the next day or 2 days later to do follow-up. So we've had situations where we follow patients up 3 times in a week and see them improve by the fact that we're able to give intravenous diuretics and other nutrients, intravenous saline in some cases, so we can manage these patients in our center. We have cardio assist therapies for patients with angina and coronary disease, and we do other therapies on site, vein ablations. But as I mentioned, the hospitalization is something that we have the capability of doing either urgently, emergently, or electively. And so the hospital is a very short distance from us. And I like to mention this because we use this as a continuity of our care for patients. So a patient is in my clinic, I may have to admit them. A lot of the nutritional interventions that we're using in the clinic and our center is also applied in the hospital when the patients are under my care. So how do we assess whether someone is clinically stable or unstable? That's really important because that's an important triage. Someone sitting in front of me in my office, how do I decide, okay, I can manage this patient here, send them home, and then see them back in a short order, or I need to send them to the emergency room right now. Sometimes it's more obvious than other times. An acutely ill patient needs immediate hospitalization. I'll make this judgment based on the vital signs, how the patient looks, oxygen saturation, a variety of data points that we look at and we put together and we make that decision. A chronically ill patient who's compromised, this is an in-between patient. They can be admitted electively or on a urgent outpatient basis, depending on, if we can see them back the next day. Sometimes we'll elect to try to treat them as an outpatient, see them the next day or 2 days later, and make a judgment then. A chronically ill and stable patient with mild symptoms, we tend to see these patients in the outpatient, but we do immediate outpatient follow-up and intervention. So if I see someone with a very high blood pressure, for instance, and then not having chest pain or shortness of breath or severe headache, and this blood pressure has been elevated for a prolonged period of time, maybe for weeks or months, I may make an adjustment in their medication, put them on a nutritional detox regimen, see them 2 days, 3 days later, or we may do a telephone visit 2 days, 3 days later. So these are patients that we can see immediately on an outpatient basis. And another example is a chronically ill patient without symptoms. Then we can do more of an elective outpatient follow-up. So this gives you an idea in terms of how we make that triage decision and how we use that judgment approach.